Hello and welcome. I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. Thank you for joining us today for the Roundtable on homing in on the patient pathway to care for heart failure. We're delighted to collaborate with the World Heart Federation to host this roundtable, to raise awareness of the World Heart Federation's roadmap for heart failure, and to bring together stakeholders from different sectors to share their perspectives. Thank you to our sponsors for making this roundtable possible: AstraZeneca, Boehringer Ingelheim, Lilly, and Pfizer. I'm looking forward to an informative discussion and leaving today with action steps to improve heart failure outcomes. Please share your thoughts and ideas today via Twitter. Use the hashtag HeartFailureRT. We invite you to ask questions of the panelists using Zoom's Q&A function. Now I'm honored to introduce our moderator, Dr. Ileana Pina, an internationally recognized heart failure expert. She's a professor of medicine at Wayne State University, clinical professor of medicine at Central Michigan University, senior staff fellow and medical officer at the Food and Drug Administration Center for Devices and Radiological Health, and I'm pleased to say, a National Forum board member. Dr. Pina, the floor is yours.
Thank you, John, and it is also my pleasure to welcome all of you to this very interesting and I think you'll find very educational video. I want to start out by talking a little bit about this roadmap of the World Heart. So a couple of years ago, during one of the European meetings, I was asked by the American Heart Association to represent them in a meeting that we were going to talk about conducting this roadmap experiment and thinking about what we wanted to put into a roadmap. Where does this come from? Well, non-communicable diseases are now taking front stage in the world for mortality. And we know that heart failure is right there at the end of a lot of things that the World Heart would like to improve, and so would we. Hypertension, rheumatic fever, different cardiomyopathies, including postpartum cardiomyopathy, which has been highly prevalent in the continent of Africa. So looking around the world, what can we do as a roadmap for heart failure? And it takes several pieces. There's a prevention part. There is an acknowledgement of the disease to make the diagnosis. It's engaging the patients. It's giving the patients the right drugs. But there's so much more to this because we're talking about the rest of the world. Our panel today will be primarily talking about the United States as a member of the World Heart Federation and putting together our thoughts. And I want to come out of this with a plan. I want to have an agenda for action. We talk about these things all the time, but let's put it down on paper and let's really put our money where our mouth is. And what can we do to do this better? We know there are barriers, and we know that the barriers differ depending upon the country, depending upon the health system, depending upon the patients and their caregivers. Remember, the patients are not just the patients, it's the family, the caregivers, and the environment that surrounds them. And all these things must be taken into consideration. And so our panel today is diverse. You're going to hear from patient, you're going to hear from nursing, you're going to hear from physicians, you're going to hear from Medicare, and you're also going to hear from the NIH, and you're going to hear from the FDA for drugs. So let me just start by introducing our first speaker, and we're so fortunate to have a patient here. We can't do these things anymore without including our patients, who are really the target and the reason for us really being here together. So I want to introduce Amy, in Spanish, Aimee Rodriguez Cepeda, who is a heart failure patient ambassador with the American Heart Association. And so I want to bring her on. And Amy, if you would turn on your video and let's bring you on. Hi, and welcome.
Hi.
So
thank you for having me.
Oh, it was wonderful to have you here, and thank you for your time and volunteering to do this. Tell me a little bit about how heart failure affected you and when. I mean, you're so young. do we really believe that heart failure only happens in older patients, or you and I know better? So tell us a little bit about your story.
Sure. Well, myself personally, I was diagnosed several years ago in my late 30s. I actually suffer from congestive heart failure, which had came into place because I have what's called dilated cardiomyopathy, and I also have what's called congestive heart failure. Now, progress on a few years in the future, where I'm at presently, I actually also have now what is called diastolic heart failure. So I'm kind of learning to deal with both. In regards of how this came about, from all the females in my family, they all at some point of time have developed heart failure. My mother has heart failure, my grandmother passed of heart failure, her mom, and down the line.
It's fascinating. I think it's an aspect that sometimes we don't ask the right questions about families and getting a good history of families. And it's so interesting that the women, it sounds like in your family, have had this. How old were you when this was first diagnosed?
When I was first diagnosed, I was 39 years old.
Amazing, amazing. We always think of it as in being in the older patients, but here you are. So tell me about your journey. Did you get treated right away? Did it take you a while to get people to listen to your symptoms and understand?
For me, it was just finding out I was just really exhausted, very tired, and I couldn't understand why. I went in, saw my primary. My primary checked me out. Within a week, they had sent me over to a cardiologist. Immediately, I went in, sit down. I was very lucky, had an amazing team that worked with me. In the beginning, the one thing that I tell everybody is you have to understand when they give you that news of that you have heart failure or whatever the situation may be, it's not the most pleasant conversation, as they do not sit there. They're not smiling while they're telling you. My experience was when I was told, the doctor handed me a box of tissues because it was kind of a dramatic moment. And all you can really do is just try to understand where the doctor comes from, as it may seem that they're being cold. It's not that they're cold. You have to understand they're talking to a lot of people at a time in reference to, similar situations or situations worse off than mine.
Fascinating. So did they start you on medications right away?
Absolutely. I'm on several different types of medication. Obviously, throughout the process, your medications change because, as we all know, our bodies sometimes become accustomed to these medications. So they have to venture. And the one thing with heart failure is there's no cure, there's management. So from now to the end of time, I will manage my symptoms, manage my medications, and just do changes along the way.
Well, God bless you. You look good.
Thank you.
I am very happy at how you look, and I'm sure your doctors are as well. If you had to give some advice to this group that wrote the roadmap and to the group that we have here today on the panel, you've seen what a diverse group of people we have here. What would you say to us?
Listen to us patients. As from the medical perspective, I understand, you guys understand what is going on, why it's happening, but as patients, we're going through it. So one of the biggest issues that I had to deal with is I suffer really bad from retention. So for me, I don't retain water as the normal individual would. So as from coming from the medical side, you would look at people's feet, you would look at their legs. So for me, I retain it in my face, in my stomach, in my arms. Then it goes to my legs. So if it goes to my legs, then I'm pretty far off as far as where I'm at, which, as far as having that fluid is horrible. So that would be one of the things that I would definitely suggest to the medical side of it. Just listen to us. As a patient and as this person been dealing with this body for, 45, 46 years, I know exactly what my body should feel like. I know exactly what my body should entail. So I know when something don't feel right.
Well, again, thank you for coming on board. Stick around and you'll hear the opinions of all of the rest of the panel, which I will now introduce one by one. But I want to really appreciate from the bottom of my heart. I know that it is very difficult to talk about these things because you're the one that's going through it. I'm hoping that they gave you some good news, that hope that we do have medications that work. And that if we can stick to your medications, it's a good chance that you could also do well. And I think that's an important message to get out there, that there's also hope. It's not hopeless. And I think that's an important message. So thank you very much, Amy. And I'm going to go ahead now and introduce the rest of our guests and then go one by one and get their points. So I've got Nancy Albert, who's a dear and a wonderful friend, and the Associate Chief of Nursing for Research and Innovation at the Cleveland Clinic and the Kaufman Center for Heart Failure. Nancy is now currently the president of the Heart Failure Society, and so I'm thrilled to have her here, extensive experience in this area. With us as well is Alana Morris, who's going to give us the clinical perspective, and she comes from the Division of Cardiology at Emory, who is known to have a huge heart failure program. They have a very extensive transplant program as well. Representing Federal Therapeutics, my good friend, Dr. Norman Stockbridge, who is the director for the FDA Center for Drug Evaluation and Research in the Division of Cardiology and Nephrology, a very important piece of the FDA that's looking at these drugs and all the studies that come through. Looking now at the federal payer perspective, I want to welcome Dr. Joseph Hutter, who is a commander as well in the U.S. Public Health Service and the Division of Policy and Evidence Review and Coverage for Centers for Medicare and Medicaid, which we call CMS. And then representing the federal policy perspective, please welcome Dr. Vandana Sakdev from the NIH. She's a senior research clinician at the NIH, director of echocardiography in the cardiology branch of the NHLBI. And she is on a detail right now with the Division of Cardiovascular Sciences in heart failure and arrhythmia branch. And then giving us the pharmaceutical perspective, we cannot forget that because we have a lot of medication choices now. We're very lucky. We have Carolyn Ha. Carolyn is the director of the Policy and Research Department at Pharma, which is the Pharmaceutical Research and Manufacturers of America, a very important voice in this discussion. And so I'm going to give each of the panelists, I have some questions for them. I'm going to ask them some points to be made one by one. So Nancy, I would like to start with you. We've known each other for a long time, and I have followed your illustrious career for many, many years, and I'm a big fan of yours as well. What does this roadmap mean to you? I wanted everybody to really read it because it's such a thorough document, and it's hard to kind of absorb it all. I think the diagrams are incredible. So what does this mean to you, Nance?
So I love the roadmap. It's well laid out. It starts off with the definition. It goes into monitoring and follow-up, and then it continues on with treatment. The figures are absolutely beautiful in it. I do think there are some pieces of it that we can enhance over time and work to overcome some of the barriers that maybe our patients are still feeling today. But I love the way it's laid out. So when I talk about, for example, enhancing, there's a great definition of heart failure right at the very beginning of this roadmap. Yet when we think about it from a patient's perspective, it's written for a professional's perspective, a healthcare professional's perspective. But from a patient's perspective, they may not quite get it. So what I mean by that is we know that, in the definition, it says it's a progressive disease. And we know it's true that heart failure is progressive. But when from a patient's perspective, they may not be having any symptoms in the moment. And I hear comments oftentimes, I don't have heart failure anymore, or my arthritis is more bothersome than my heart failure. And so I think it would be great if, in addition to the health care provider definition, we can look and develop a patient version of a definition so that it really makes sense to patients, so that they can understand that the heart may be getting bigger or the remodeling may be changing silently. They may not be having worsening symptoms, or they may just not recognize worsening symptoms, because in fact, what may end up happening is they've stopped carrying out the behaviors that got them into trouble. So when you and I ask them at a clinic visit, how are you feeling? Patients may say, I feel fine. They may not even recognize they have worsening symptoms. So the roadmap is really set up well for healthcare providers to really be able to understand the big picture. It's beautifully done. But if we can also weave in somewhere in this roadmap the patient's perspective, it would really, I think, enhance the overall piece from a global standpoint.
I think Amy's experience, as she just shared with us, is so telling, that the physician told her that she was sick and handed her a box of Kleenex because the word failure has this terrible connotation. We've been trying to come up with different names for heart failure, and we always end up the same. So Nancy, put that in your thinking cap for what is the next thing that we need to do. Now, you had a very interesting late breaker at the American Heart Association. Can you just briefly, in a couple of minutes, tell us that? Because that was so patient-centered. I was there to listen to it.
Thanks so much for asking. So we conducted a study. This all started because one of our IT professionals, not a nurse, had her 85-year-old mother in the hospital for heart failure. And when her mother was discharged, she went to the home and she said to her mother, what did they tell you at discharge? And her mother said, I don't remember. They were all coming at me with all this stuff. I don't remember anything. So she came up with this novel idea to develop a card. And we've all seen greeting cards that when you open them, they play music or do something cute. This greeting card, when you open it, it says, we care about your health, and here's some important information for you to take care of yourself at home. And then there's 4 buttons on the inside, one for diet, one for medications, one for self-monitoring, and one for physical activity. So in the research, we actually opened the card, let them listen to the initial message, and then we pressed the physical activity button. And we were strategic in putting that button in the top left, like the first button maybe you'd press if you went in order, because we believe that physical activity, even walking, getting up and moving, is very important for patients with heart failure. Yet we also know that many patients are not given explicit instructions. They're told, do what you can, or you'll know when you need to stop. And so as soon as they get a little short of breath or fatigue, they stop. So we put that in there and sent this home and studied patients at 30 days, 45 days, 90 days, and 180 days. And a lot of people would say that's a soft intervention. You know, everybody's already educated, and everybody in the usual care group got usual care education. And we have a very nice binder we give everybody. It turned out patients in the My Road group, the card group, in addition to getting usual care education, had a significant decrease in 30 and 45-day all-cause emergency department visits, 90-day death rates, and they even trended toward 180-day reduction in death. And they had a strong trend in a reduction in heart failure, or all-cause hospitalization. The hospitalization did not reach significance. But when we did a composite outcome, the composite was highly significant. So not only can patients feel better, hopefully, and not need to be hospitalized or go to the emergency room, but they may live longer just by being able to repeat messages, the same message, and we made them actionable. So it's not just you need to exercise. The message told them what to do. You know, start out slow for 10 minutes, work your way up to 30 minutes. And so we gave action-oriented messages. And in some patients, obviously not all of them, those messages seem to make a difference in their outcomes.
So in this pandemic where we can't always get the patients back in, it's sort of like taking you with them in the home And one of my nuns always said that repetition is the mother of learning.
Yeah.
And repeating the same message again and again, it's human nature.
The other thing is that a family member comes over, and we actually instructed the patients to share it with their family, and we wanted them to press the button. And especially, you could imagine if somebody's in the kitchen or being busy and the daughter comes over and says, "What are you doing up? You just got home from the hospital. You should be resting." And we actually said to the patient, have them press that button because it says you should be active. And so now that maybe everybody will be on the same page with what is important in terms of self-care.
Changing the concept. So keep that in mind as we come up with an agenda. Thank you, Nancy.
All right, thanks.
My next guest is another good friend, Alana Morris from Emory, who is on the front line like we are with the heart failure population. Alana, welcome.
Thank you so much, Alana.
You do this all the time, and you have a population that many of them have a lower socioeconomic level and probably a lower health literacy level. But they get sick and they have a lot of risk factors. So what does this roadmap mean to you as the heart failure clinician right there in the front lines?
Absolutely. I think one of the things that I really liked about the roadmap was how we really broke it down into what we could do at the level of the patient, what we could do at the level of healthcare workers, and what we could do at the level of the system, because there are changes that need to be implemented at every single level. As we've all recognized, heart failure is a very, very complex condition. And we tend to focus a lot on engagement with patients, but in fact, there are changes that really need to be made at every single level. As Nancy pointed out, the complex self-care that these patients require is enormous. And we need to make sure that we educate patients to make sure that things like exercise, of course, restrictions related to sodium and fluid are given to all patients, but we know there's an exceptional amount of variability in terms of what we tell patients, depending upon whether they're followed, for example, in a primary care clinic versus a advanced heart failure clinic, or even a general cardiology clinic. We need to hopefully have standardized instructions to make sure that people are getting sort of the right instructions. We know right now there's sort of this explosion of new heart failure medications, which is amazing for you and I as the clinicians prescribing these medications. But we also want to make sure that the prices of those medications are not out of reach for our most vulnerable patients. I think that's so important when we look at not only these new medications that have, in many cases, incredible efficacy and incredible effects on morbidity and mortality, but then when we write patients prescriptions for those drugs and they go to the pharmacy and they're multiple hundreds of dollars per month, that's a real barrier for many of my patients. And I find it very difficult to explain to a patient why it is that a medication, which is often one of 5, 6, 10, 15 medications that they may be on per month to treat a chronic condition, costs as much as sometimes a gas bill or a light bill or rent in many cases. So I think that's something that we need to think about from a systems perspective. As far as what we can do as healthcare workers, again, there's so much variability. Eliana, you and I, are both familiar with the data from the CHAMP-HF registry that showed that even for some of the older medicines that have been around for decades, ACEs and ARBs, beta blockers, the mineralocorticoid receptor antagonists, when you look at utilization of those drugs that we know improve morbidity and mortality, that unfortunately they're not prescribed at the level that they need to be. And I mean, there's just no good reason for that, because in that study, they documented that those medicines were not being prescribed, but there wasn't a contraindication documented. So why is it that as healthcare providers, we're not doing and not prescribing the medications that we've known for many, many years will keep our patients out of the hospital and keep our patients alive? And then at a systems level, I think there are so many things that we can do to stop the revolving door of hospitalizations for patients, identifying the patients that are high risk and trying to make sure that when they're in the hospital, that we're changing their medical therapy, that we're not sending them out on the exact same medications that they came in on. Those are the highest risk patients, and we want to make sure that we're taking the opportunity to optimize their care.
And some of the drugs, maybe not the newer ones, the older ones are very inexpensive.
Absolutely.
And they're generic. And I know that, you know, places like the big drugstore groups and the big Target, Walmart groups have them for a very, very low price.
Mhm.
That would be a place to begin.
Absolutely.
So as we move on, I want you to think about, when we come back for the discussion, what can, from your point of view as the clinician, right there, you know, in front of the patient, what can we do with this roadmap to come up with an agenda of action for the prevention? We've been talking about it, you know, that at the American Heart, we've been talking about it for a long time. And boy, if anybody would just control blood pressure, we could lower their chances of having to see us by 50%.
Absolutely.
And that's part of the roadmap issue as well. If we could only control blood pressure, and yet people feel well when they have high blood pressure. So that's why we call it the silent killer. There's one of the biggest barriers to care. So think about what you would add as a plan for us at the end of this. And I want to thank you for your years of experience and the wonderful care that I know you give your patients.
Thank you so much.
So I am moving right along with the federal side of things, and I want to invite my good friend, Dr. Norman Stockbridge, to come and join us. And Norm, you see these drugs all the time. You see them come to you for approval. You see them come to you for an extension of the label that you already approved, because now they have a new patient group that they want to describe. What goes through your mind when you see this roadmap and your years of experience in the heart failure drug world?
Right, I very much appreciate the opportunity to have looked at the roadmap and offer some personal observations on it. You know, I carry around, I guess we all carry around a somewhat simplified model of, you know, what are the important things to do. Prevention is on my list. Diagnosis is on my list. Getting people prescribed the right therapy is obviously on the list. And then I think about adherence to medication. It's interesting. I mean, all of those things are covered in this very ambitious document, but adherence is not prominent in it. And I've at least thought it was maybe the highest leverage factor in how well we could do here. But you know, that discrepancy between, you know, my bias about what might be important and what seemed to be the way in which this was approached in the roadmap made me wonder whether you know, we were missing an opportunity really to take a more data-driven approach to setting an agenda. You know, if you had a way of estimating, I mean, maybe that's not important, I don't know. If you've got an unlimited budget for approaching this problem, maybe it doesn't matter. You know, you can attack all facets of this simultaneously. Well, that's great. But if not, it's worth spending some time, I think, and trying to figure out, you know, which of the many factors that are addressed in this roadmap, you know, can be addressed with, you know, something as simple as a talking greeting card, and which ones of them are going to take, you know, big infrastructural changes to implement, and then what's the likely return on those investments. I think having a better handle on where people should really put their resources would be an important early step that I don't think is represented in this document.
I think you brought out a very important point that maybe we can readdress, because maybe that's something that we can do. Just so you know, the American Heart has just published the medication adherence paper. It got published in Progress in Cardiovascular Disease so that we could have a broader audience than just singing to the choir, which is us. I have often counted the number of medicines that patients leave the hospital with. They leave the hospital with 13 drugs. How can you take 13 drugs in a 24-hour day? That would be all you do. And we always try to simplify the regimen. But the regimen, as you well know, is getting more complicated. You have at least one drug right now on your desk for approval, probably another one coming. And we're talking about the pillars of care that include, you know, the basic neurohormonal and now the SGLT2. So it's getting more complicated. It's not getting simpler. And I think adherence is crucial because as I started the paper saying, drugs don't work in patients who don't take them. And that's essentially what it is. So I want you to hold that thought, and we're going to come back to you when we do our panel. Thank you, Norm. I know you are extremely busy and we appreciate your time.
Glad to be here.
Thank you. Next, I want to introduce again Dr. Joe Hutter from CMS. CMS gets blamed a lot for all our ills, and poor Joe is carrying it on his shoulder. But Joe, thank you so much for coming. I mean, you have extensive experience, and thank you for your service, by the way, as well, with the Public Health Service.
Thank you.
So what does this roadmap mean to CMS, and what do you think are the roadblocks that you can help us with?
Yeah, so I think, you know, one of the key parts of the roadmap is, can we provide strategies for overcoming roadblocks? Payment and coverage is often a roadblock. Let's be frank about it. So what I'd like to do is just very brief tour that cuts across the different programs in the centers for CMS that touch directly on heart failure patients. And so I'll talk a little bit about the national coverage determinations, but also the latest changes in the bundle payments program coming out of the Innovation Center. If there are more questions later about quality measures for the fee-for-service system, we could get to that, I think, a little bit later. Basically, so in the coverage group, I was a lead medical officer on a number of national coverage determinations, such as for ICDs, for TAVR. And I'm happy to say, actually, heart failure as a field has been in many ways a poster child for the successful development of interventions. You know, get this thing, build this thing, get coverage for it, and then achieve nationwide diffusion of best practices across it. So the main reason isn't really that a handful of bureaucrats were finally listening to experts on the outside. It's really because academia and industry have teamed up and produced interventions that actually work. So we've seen, all of us have seen, that optimal medical therapy has improved dramatically over the past couple of decades. And then the devices, whether it's CRT, ICD, TAVR, in heart failure patients, have all decreased mortality and are useful for wide segments of our Medicare beneficiaries, those patients who are similar to the patients that were included in those randomized controlled trials. Jumping to the Innovation Center, I was an acting director over within the Innovation Center in a diffusion and learning group at a time when a colleague, Steve Farmer, who's a cardiologist, was trying to rebuild the quality measure program for the bundle payments. He went on a listening tour out there to experts and frontline, you know, his fellow practicing cardiologists, and heard loudly and clearly that there's some problems in the program. And the main thing there was that cardiologists and other specialists too had the same complaint. They weren't engaged because these administrative claims measurements that determined your payment and are you succeeding or not were very broad, very general, not related to what actual cardiologists did in their practice day to day. An example would be all-cause readmissions. Well, a patient could come in with a GI complaint, be treated by a hospitalist, but because they had heart failure on their problem list. Right? They may not have been in acute heart failure. That was not the cause of their admission. They might have been treated by the hospitalist, not ever gotten a cardiology consult, and boom, cardiology participated in this program, was hit with a readmission. And so he went to align that. And right now, just sort of very briefly, there's a whole new way to do this. So you can choose from that old administrative claims approach, 7 broad areas, or you can choose a new approach that's aligned, that is more basically clinically aligned and actionable. Those are Steve's words, and I think they're very powerful. He's aligning these to actual clinical registries. So you go in and pick out measures that actually are something that you can control and that are actionable. You can look at how you are doing and say, here's how I'll change management of patients in front of me. And you're no longer basically bound to what a larger group is doing. There is a role for that. That's called an accountable care organization. But within a cardiology bundle, and now there's like a cardiac care clinical pathway you can go to. Unlike before, you can't just choose one area. You can't say congestive heart failure, but I'm going to ignore arrhythmia or acute myocardial infarction. If you're choosing the cardiac care clinical episode service line group, you're going to do all 3 of those within there. But then you're not responsible for things outside of that. And the measures you select from this big chart can be more clinically relevant, and they're aligned to the registries that you're producing and participating in. So why don't I just leave it at that for there? There's certainly a lot of other questions that may come my way, and we can get to that eventually.
So think about that for our meeting. Again, I can tell you that as we have done some economics and heart failure symposium during the Heart Failure Society meetings, how many of our attendees had no idea if their own health system took part in any of these programs.
Yeah.
And so getting that information from the health system to the physicians and nurse practitioners that they cover is equally important. And then finally, what you heard from Nancy very clearly is that every time we look in registries, we're not doing such a good job with that guideline directed medical therapy. And we often get a lot of resistance when we try to put it in from the top and say, you need to get better at this. You need to do better with the medications. Why? Because it will show up in lower readmissions and it will show up in better outcomes. But there's a lot of resistance. And so maybe dangle the carrot, or push the button. But it's been very difficult. Not your fault, but there's system things that I think also need to be addressed for this roadmap. Joe, thank you. Always a pleasure to hear you. And you can tell Dr. Farmer we said hello.
Certainly
He's
will.
a great guy. Thank you. And next, I want to welcome again Dr. Vandana Sakdev, who is from the NHLBI. I would love to hear about how your work would play into this roadmap and how you would take the roadmap and play it into your work. Thank you for joining us, Vandana.
Hi, thank you for having me, Ileana. I appreciate the opportunity to be part of this, and I'm going to give you my perspective. It's not the official position of NHLBI or NIH, but I want to address 2 main points. The first one relates to prevention of heart failure, and Ileana, I'm glad you already mentioned blood pressure control, because I think this is a really important area. A couple of months ago, there was a publication from the NHANES study, and they talked about a decline in overall US hypertension control rates. And we know this has a big impact on heart failure incidence. So if you look back about 20 years in these cross-sectional surveys, the control rate in people with blood pressure with hypertension was 32%. Now this got better over the next several years. And then after 2013, it declined to 44%. So in early October, we held a joint workshop with CDC to convene diverse stakeholders, and we wanted to discuss barriers and possible solutions for this national decline. I think that's very relevant to some of the things that the roadmap talks about. So the discussion in the workshop focused on overarching barriers to achieving blood pressure control, and some of these are very obvious: a lack of clear messaging to patients on how important it is to prioritize blood pressure care. I guess this is part of the bigger problem of patients dealing with lack of insurance, underinsurance, lack of access to care, social determinants of health, those are big issues. But things like team-based and community-based management of blood pressure, those are important barriers that we could possibly do something about. Currently, they're somewhat limited by coding and reimbursement. Another issue was that primary care providers are the ones that usually handle this type of management, and they're dealing with multiple chronic conditions, obesity, diabetes, and they're experiencing overload and clinical inertia. And then patients, we instruct them to check their home blood pressure, but then the IT infrastructure we need to capture this data to inform clinical decision-making is outdated and not very easily usable. So there are a lot of other challenges and barriers, but we also had a good discussion of potential solutions. And let me tell you a little bit about that. One thing that was suggested is that we need broad public health messaging, similar to what was done for smoking and salt intake. We could better motivate patients to become engaged, to participate in their healthcare. But in order to do that, we need to make it more convenient, have virtual delivery of care, especially for simple things like blood pressure management. And another thing that research has shown is successful is team-based care with pharmacists, nurses, community health workers. If we can tighten that link, that's something that's very addressable. And many of these solutions are things that can be implemented worldwide. Here in the US, the Surgeon General, most of you probably know, released a call to action for blood pressure control just a couple of weeks, a month or two ago. This report provides translation materials for partners in many different sectors, potentially usable worldwide. In follow-up to this call to action, there's now an HHS-wide leadership group, and they're looking at all governmental efforts to prioritize blood pressure control. So that's potentially an effort that we could latch onto and collaborate with. The second area that I wanted to get into is that the roadmap starts with a definition of heart failure and guidelines. And, we talk about heart failure and all of the medication options, but what about heart failure with preserved ejection fraction? That definition is different depending on what trial and what study you look at. And really, there's no good treatment guidelines. And so that's a big barrier, the diagnosis and the treatment of that big group of patients. And so that's something that we really have a lot of interest in. It's one of our main strategic vision pillars, things that we want to focus on. So let me tell you a little bit about a program that we're working on. We released 2 RFAs that support a program called HeartShare, and that's a deep phenotyping program focused specifically on HFpEF. The goal of this program is to conduct large-scale analysis of phenotypic data, images, and omics in order to better define what is HFpEF, what are the different subtypes within it, and can we characterize the mechanisms and look for therapeutic targets. Those are big research areas that I think will definitely improve the diagnosis and treatment of these patients. I could tell you a little bit more about the details of that in the discussion, but some of the unique things that we're doing in that program, we're using electronic health records. We're doing a lot of patient participation in the research process, not just in enrolling patients, but having them actually participate in planning the study. We're trying to use a lot of digital tools, remote consenting, online surveys, wearables, all kinds of home blood pressure, actigraphy, home sleep monitoring, anything we can do virtually and easily so that more patients will participate. Finally, we're also trying to partner with industry because that's where the drug development expertise is. So we're planning a public-private partnership with several companies who want to build upon this program and try to help us identify the different subtypes that can lead to precision therapies. So I'll stop there and happy to take questions later.
Thank you. I think as you were talking about the hypertension and the prevention of heart failure, I bet you most of those are HFpEF. And every time we look at a HFpEF trial, the amount of hypertensive patients in it is huge. And I know in my own population, it's something I've always tried to do is get those blood pressures down. And I don't think as cardiologists, I don't think we've paid enough attention to blood pressure. We sort of relegated to the primary care, or we relegated even to the nephrologist if the blood pressure gets a little bit tougher to treat. But one thing that I have noticed in my own neighborhood, and especially after the pandemic, people used to go to the local pharmacy to measure their blood pressure in one of these machines that you just stick your hand in. Well, that's now been removed because of the pandemic. So Here's the perfect place, the local the local Walgreens, Rite Aid, CVS, I don't care which chain you want to pick, that's where the patients often go to get food, to get their medicines. They get a lot of things. They do shopping in there. What a wonderful place to measure their blood pressure. And it's not easy to get your blood pressure measured anywhere. You have to go make an appointment. So if we can bring the community, like you're saying, to the blood pressure cuff, rather than trying to find the cuff to bring to the community, I think to me that would be a tremendous advance. And maybe that's something that we could include as one of our agenda items or action items. But I think I love the fact that NIH is really into this, and look forward. I hope you publish the proceedings of your CDC.
Yeah, definitely. That's in the works. Thank you.
Sounds phenomenal. Thanks again, and we'll have you right back to our Q&A. And then our last speaker, last but not least, I have Carolyn Ha, who is a PharmD, and she's coming to talk to us from pharma. So Carolyn, you guys have been wizards at making drugs for us, and you've taken the need and you've translated it to the science. And science is how we do things. And I think we all of us here are scientists. What would pharma's role be in this roadmap? How do you see yourselves?
Yeah, thank you. Good afternoon, Dr. Pena, and thanks for having us on. I think it's been really inspirational to just hear all the different perspectives, starting with the patient and on down the line. And, you know, pharma and our members are really pleased to be a part of this. I echo all of the kudos for the roadmap. We do believe it's beautifully done. If, you know, I think if we were, I think as Nancy had suggested, or maybe in a version 2.0 or, you know, other, you know, iterations of the roadmap, hopefully it's just the starter. You know, I think as you've heard from some of the previous speakers, there's already a lot of industry collaboration that's going on, you know, and, you know, in terms of, you know, FDA, NIH, but also in the communities. One thing that I did want to kind of highlight or hit on is how important it is that we're having this conversation even in the midst of this pandemic, because I think if anything else, what we've really learned is just the importance of managing chronic conditions and what that intersection has meant in terms of a patient's risk propensity for worse outcomes and progression, even with COVID, right? So it has really shown a spotlight on the need for prevention and management of chronic diseases. And yes, I do believe that, you know, our industry is resilient, and we have, you know, I'm so proud to represent the scientists who are on the bench and researching these medications. And, you know, there have been, you know, there are 200 medications in the cardiovascular pipeline today. We have 40, you know, just for heart failure alone, that's in the pipeline. And, you know, there's very amazing, you know, cell and gene therapies that are coming on that could really change the landscape of how we treat the disease. But the other part of this too, and you know, it was touched on in the roadmap, and I think what resonated with us as well is the social determinants of health, not forgetting that we're only as effective in the development of our medicines if we have representative participation in the clinical trials themselves as well. And so that's another piece that I wanted to raise as we think about the entire life cycle of medication development, even before it reaches a lab. You know, pharma was really pleased earlier this week to release first ever industry-wide commitment and principles to clinical trial diversity, to really reach out to underrepresented minority communities where we know that historically there have been a lot of mistrust, you know, misinformation about the healthcare system. I mean, that's like their first kind of interaction with the healthcare system. So before we can even talk about other barriers, you know, trust and working with healthcare professionals. And I love the piece about, you know, working with community workers, would love to get to those solutions. You know, the other hat I wear, you know, was working in the community as a pharmacist. And so would love to talk about those multidisciplinary approaches. You talk about the checking of blood pressures in the pharmacies. But, I think back to kind of fundamentally, before we even get to the development of a drug, ensuring that, we're reaching out to underrepresented Black and Brown communities who have previously been mistrustful, because we can only develop the best medicines we can, but, it might not be a representative sample in those clinical trials. So, and we know, again, the disproportionate share sometimes in cardiovascular disease, heart disease, hypertension that may be affecting these communities of color. And so that really drives us as well in terms of the science and following the science. So I did want to just spend, I wanted to touch on that as well, because as great as we are and as proud as I am of the industry, I think I'm even prouder to say that we're recognizing the importance of diversity in clinical trials and what that means for ever excelling in medication development.
Thank you, Carolyn. We've been fighting that fight for a while of trying to get representative populations, and I am especially astounded, and you're going to see it in print very soon. We actually reviewed the late breaker trials in the past 3 years from the major organizations. And let's say that out of 23 presentations, there was only 1 or 2 that actually listed a different race and ethnicity in the population. And one of the things that I think we've identified is that, patients like us, doctors like us, we don't have enough of the diverse patient in the investigator pool. Is not as diverse, because I know from being a Hispanic that the patients feel so much better when they see a Hispanic physician taking care of them. And even being able, in my case, to speak their language, because that's the language they revert to. So, appropriate representation in the investigator pool is so important, but it highlights a lot of other things that have been going on in society. And I think that, this COVID pandemic in that lower socioeconomic group has really highlighted. And, when we saw this, most of us said, duh, I am not surprised at all that these are the highest risk patients for dealing with this horrible, horrible disease. So I also want to point out for you that, the World Heart Federation also is talking, and in this roadmap, we have it about identifying target groups with heart failure. You guys have developed now drugs for amyloid. I know that in the past, I wasn't searching for amyloid, because even if I found it, what was I going to do? And so the fact that now I can identify those patients earlier is really due to you guys sitting at those labs bench desks and getting us the drugs. But now we need to teach the providers how to go look for them. The patients are there, you have to go find them. They're not going to, raise their hands and say, hey, I have amyloid. But it links the other conversation we had about HFpEF and the conversation they were having about hypertension. They're all kind of linked together. So I want you to stay right here. I'm going to bring in the rest of the panel. If we could do that, if you guys are listening to me. We have a few questions in the queue, and I'll start looking at this. So I'm going to bring in the rest of the panel. Just imagine we're sitting around a table talking to each other. I just can't offer you the coffee or the tea. More? Terrific. So I think we need to bring Amy in. One more.
I'm here.
Okay, so you can hear us all right, Amy, up there?
Yes, ma'am.
Okay, thank you. I hope you've enjoyed this discussion. Very often patients aren't purview to listening to this. So we have a goal to come up with, let's say, 3 things that we can do immediately, and then maybe 3 things that we can do in the longer term. So I see our action items as short term and long term. And something that the National Forum, remember the National Forum is the convener of organizations. And we have incredible number of organizations who are members who would be able to share some of these dreams perhaps that we have. And if you go back to the roadmap, there are some tables, and table 3 talks about improving awareness. So let me address that first. How can we improve awareness? People confuse heart attacks with heart failure, and they confuse sudden death with a heart attack. And I haven't seen, a huge, other than some of the pharmaceutical companies advertising their drug for heart failure as being about the syndrome in itself, as I call it, a syndrome, not a disease. Any thoughts on that, on the improving awareness business?
Yes, absolutely. I think one of the key aspects to improving awareness is to ensure that you have folks that look like us. There was a couple of people that was in the panel today that spoke of that. I know for myself personally, I didn't really see people that I could identify with. And I hate to say it, even though I hate to say it, even though the aspect of it is true, but unfortunately, even as adults, we don't listen if we can't identify with what we see. And what I mean by that is, for me, when I was dealing with heart failure, even though I knew I had a family history of heart failure, I still identified heart failure with someone in the 60s, 70s, 80s. I thought of elderly. I did not look at a 39-year-old young woman that I felt was in decent health. I did not identify with that just because of the fact that I didn't feel that pertained to me. Even if you look at on TV now, you'll see a few people out there that look like me that have heart failure, but again, they're still up there in age. So I think what we need to do is we really need to make sure that we're getting that information out there to everybody across the board, regardless of age. And that's one of the things that, I was very happy to see that American Heart Association, you guys, and I see a few other companies doing that, is that you guys are trying to make sure that my age group understands that, hey, this can affect you too. You need to pay attention. As you said, we're seeing during this whole COVID moment that it's affecting a lot of the communities that really wasn't paying attention to how it could affect us because of all the other things that we have going on.
Very insightful, Amy. Joe?
Yeah, so I just wanted to jump in on that. Education is so important, and 2/3 of the people on this call are educators now or have been in the past, and yet we often know that education alone is not enough, right? With the exception of smoking cessation, it is really hard to have lasting, substantive impact with education alone. So what are the programs and incentives that we could use to engage people? And an old idea is, can you leverage, and it builds off of what Amy was just speaking about, right? Is have people like us as part of at the table. And if you can take Muhammad Yunus's approach for microfinance, leverage social equity, right? So you have a community of actual people, not just experts, who are engaged, and they're focused on what we would all agree is the most important thing, which is prevention. And there's primary and secondary prevention, prevent disease from onset. But then if you have a disease, making sure nutrition, exercise, adherence to the medications don't save lives. Taking the medications saves lives, right? It's just like vaccines don't save lives. Vaccine administration saves lives. You focus on that upstream solutions and leverage that social equity and put patients in the forefront of care of each other. And that's easier said than done, but I think that's where we need to go more and more.
But I agree 100%. But again, I think the question is, how do we get that done? We've heard multiple people on the panel, for example, bring up control of hypertension as a preventive strategy to prevent the onset of heart failure. I used to be on faculty at the Veterans Affairs at the VA Medical Center here in Atlanta, and one of the best things about working at the VA was that I got to prescribe any patient a blood pressure cuff. They could just go downstairs and get one. And we sort of wonder in this day and age, why can't we do that for any patient anywhere, particularly now that we are doing so much virtual telemedicine? How on earth can I manage patients who are either at risk for developing heart failure or who have heart failure if they don't have a blood pressure cuff? As Ileana pointed out, many of my patients, I used to be able to tell them, that's okay, you don't have to buy your own cuff, just go to your local Walgreens or CVS or Rite Aid and just use the cuff that's there. But now in the era of the pandemic, that's no longer an option. We think from a population perspective, a blood pressure cuff as an intervention for all of these patients at risk is so cheap on a population level in terms of preventing the onset of disease or in terms of secondary prevention for those patients who are at risk. But there are so many patients, particularly our patients who are low socioeconomic status, who don't have one. And that's such an easy intervention that we could make on a population level for our patients to try to help them manage their disease.
The other thing we need to consider is, when it comes to awareness, when people have either dyspnea or fatigue, they don't understand that it may be part of heart failure because nobody thinks they have heart failure. They think I was stressed the day before, I was busy playing with my grandkids, I've got the flu, I've got a cold. We make a million reasons why my asthma's coming out, I've got allergies. And so when we think about awareness, I agree with Amy, we need to put context to it so people can understand that it affects different races, it affects different age groups, and so people can see that. And in addition, we need to help people understand what fatigue really means and what shortness of breath really means, and ask them, is this you? And get them to think about the fact that it may not be their asthma or their iron deficiency or something else that they have, so that they can seek care and get that initial appointment made so that they can start on that journey to find out what really is the problem. It may not be heart failure, but what if it's renal disease, or if it's atrial fib, or if it's some other condition that causes these same symptoms, so that the patient may still need care. And I think we do a good job of having campaigns. We had the FACES campaign a while ago. When CRT first came out, Medtronic did the Know Your EF campaign, but we haven't had a sustaining campaign or one that goes on over time that maybe changes and morphs it up so somebody is aware and pays attention to it.
And here's a very simple campaign that maybe Vandana can chime in on. What is a normal blood pressure? I mean, I have family who are still trying to tell me that 150 is normal because they're 50, so 150 must be normal. And that was the way my mother thought. And that mentality has not changed. And Amy, probably in your population is exactly the way your family has thought about it. 150 is fine, I'm 50, and when I say, no, I want you down to 120, and they'll say, oh my God, I'm gonna pass out. So where do they get that information? If they go get their blood pressure taken, do they get a little sheet of paper, a little card, an American greetings card that says, my blood pressure is this, your blood pressure should be this, and 150 is not normal, that's high. Where do we get that? Vandana, where do we get that?
Yeah, thank you for that question. That's one of the topics we actually covered in that workshop I mentioned. And, I think there was some consensus that with all of the changes in the recommendations between JNC 7, JNC 8, and then the different AHA-ACC guideline recommendations, there has been a little bit of confusion created, partly among clinicians. And do we treat everybody to 140/90? Do we still do diabetics and chronic kidney disease differently? There is a little bit of confusion with all of the changes. And if the clinicians are a little bit confused, then obviously patients are going to be confused. So you're absolutely right that that is a big topic. I don't have the solution for that. I want to bring up one thing as others were making comments, and this is somewhat of an out of the box idea. But there is, you talked about convening different groups. There's a sector that I think could potentially make a lot of impact here, and that is the technology companies. And I'll tell you what I'm thinking is I have an echo background. I run an echo lab, and we now have echo probes that you can plug into an iPhone. So why don't we have a blood pressure cuff that we could plug into a smartphone, right? There's a lot of technology in the hands of people worldwide, and it seems like we should be able to do blood pressure cuffs the same way. I'm sure people are working on that, but maybe that's a sector that we could include and somehow brainstorm to get, you know, economic advantage to them, to incentivize them, but also benefit for the rest of patients that are suffering from this.
Not only will it benefit patients, but it'll benefit all of us in the telemonitoring mode right now, because we're doing telemedicine, and I still have patients that I have to talk to on the phone because they don't have all the equipment. I can't get objective data. And so if we can figure out a way to keep it simple, but make it important for us to get the information we need, that would be wonderful.
But I want to get Amy's environment involved as well, because if she had been in an environment where other people understood that heart disease is not just for the old, that it happens even at younger ages, she may have realized and gotten some comfort from knowing that. So if we look at blood pressure, then getting the community taught better about blood pressure. I mean, we call it the silent killer, and I'm not happy to be losing friends to cerebral bleeds because they haven't taken care of their blood pressure through the years. And these are young friends. So it's a killer. And so maybe that's a simple plan for us. I want to move on to improving access to diagnostic tests, which is part of the table in the roadmap. It's table 4. How do we get the patients in? Alana, you deal again with a tough population. How do you get them in there to test them?
I mean, again, I think that one of the luxuries that we have in an advanced heart failure clinic that perhaps is different than a general cardiology clinic or even a primary care clinic is the luxury of time. If I am, so lucky, I can sometimes spend 30 minutes with a new patient in my clinic, and I use that time to educate patients. And you would be surprised, again, in heart failure, at least in reduced EF heart failure, as we've mentioned, there's polypharmacy, and we do that on purpose, but many patients are coming to me still not understanding why they have to be on the ACE inhibitor and spironolactone and the beta blocker and this, and they've been on those medicines for years, but no one has ever taken the time to explain that those medicines are not for their blood pressure. They all do something different in terms of, sort of attacking the pathophysiology of the condition at its core. And so I think once we take the time to really educate patients and make them understand what we're doing, why we're doing it, they really start to engage in a very different way. But unfortunately, sometimes when they come to our clinic, it's the first time that they've heard that information. I think that education actually can be independent of health, sort of initial health literacy or education. Again, it just takes time for us as clinicians to engage patients and sort of meet them where they are. And they all can really be brought to our level. And once they engage, they really, I think, can have a lot of fun, if that's the right word, perhaps, in terms of thinking about, I want to know what my ejection fraction is, doc, like, let's get another echo. Here are my daily weights. I'm bringing in my blood pressure log. But again, it's that initial engagement and really trying to get them to understand why we're doing what we're doing, why we're making certain changes. And it can really change the course and the trajectory of many patients' condition.
I think you're really describing the word engaging the patient, and it goes to Norm's point about adherence. If you don't understand why you're taking something, you may be more willing to skip it. And one observation that we made, and Nancy and I have talked about this during the middle of the pandemic when it really started getting bad. And on the devices side of FDA, we were concerned about trials going on in the middle of the pandemic. Well, heart failure admissions all of a sudden dropped. And I think they dropped at the Cleveland Clinic as well, Nancy, there for a while. I know friends of mine in all these programs, and we were all scratching our heads saying, are they just sicker at home? Well, maybe they were like taking their medicines for a change because they were so scared. They didn't want to come in, but they were actually taking their medicines. They were eating at home, so probably better sodium content of food. And someone who was hovering around there was taking really good care of them so they wouldn't get sick and wouldn't have to come in. So that to me, that just opened up that whole adherence issue very, very much. And so again, that engagement, Norm, you brought it out so well, would improve adherence. I think patients tell us what we want to hear when we ask them if they're taking their medicines, because they want to please us. Patients really do want to please us. And instead of asking them, I never ask them anymore, are you taking your medicines? I usually say, in a typical week, which of these are you likely to, forget, or you didn't take with you when you went out? And I'm already acknowledging they're not doing it. And I usually will get to the truth a little bit faster. So think about that. We were also being asked a question about PSAs on TV. People still watch television, and now we have 1,000 channels on all these cables, and most Americans, I think, at least have a television set. So public service announcements have just about disappeared from television. I remember as a kid there were public service announcements. They're gone. Anybody want to comment on that? Would pharma like to do public service announcements?
That's a great question. I mean, I think that there's a lot of patient education that our member companies and we engage in. And so, there's a lot of important conditions we have certainly been a part of and been happy to support, various initiatives. Those are typically done in conjunction, for example, with the CDC or FDA or NIH. So we're certainly open to more patient awareness and education campaigns. The other thing I did want to touch on from Dr. Morris too is, I've loved these community-based models and extending kind of the healthcare provider into places and meeting the patients where they are. So one of the great examples that I think has worked well in a particular city that might be able to be replicated is bringing those blood pressure cuffs to like a barbershop, right? Which is where a lot of people go. If you think about places that patients might even go more often than their doctor's office, because it's either hard to make an appointment or you only see them once every 3 or 6 months. And even with the pharmacy, they maybe only go once every month. But feeling that sense of camaraderie, that sense of community where, they're likely to even just go to a barbershop or their church group just to hang out. And that's where their tribe is equipping those places with a blood pressure cuff as well. And empowering those in those communities, and whether it's the barber or others to know that 120 or 130 is the goal, and using them as extenders of healthcare providers is another model that I just want to throw out there as, simple low-tech solutions that can extend that conversation beyond, the four walls of a clinic.
Yeah.
Joe, did you want to comment?
Yeah, no, that's exactly that idea of let's leverage social equity that you just spoke to that very eloquently. And, as far as public service announcements, it's like, maybe that is something. That is what was very successful with smoking cessation. It was one thing. It was hammered at a national level. It was an easy message. And, and in the first, Surgeon General's report or whatever, there wasn't a single randomized controlled trials, but there were 7,000 references that went to this case of yes, actually smoking causes lung cancer. So that was something that was amazingly effective. And having, one thing we've learned with COVID, my wife works on Operation Warp Speed. I'm working on the RADx, the diagnostic testing arm of this whole thing. It's 2 Manhattan projects. It's the public-private partnerships that we've done in the past now on steroids and working in parallel. And you know what? Here's a bureaucratic roadblock. Let's just blow through that. Not lowering standards, but blowing through some of the time schedules that we had baked into our brains. And so if you find something like, yes, we always knew that lowering blood pressure was important. Now we're learning just how important it is. And it's a clear message. It's a single focus. Yes, there's a lot of things that are important, but you can take one thing, leverage the social equity like you just described so well, right? And then incentivize it, because and then you have that national campaign led by the Surgeon General, public-private enterprise. I'm not volunteering my boss's boss at this point, but something for you to keep in mind, right? So you do that. You do that social equity stuff and make the tools available that you need to make this work, right? And then the third arm of the third leg of this stool, incentivize it. I'm incentivizing providers, nurses, doctors. I'm incentivizing the patients themselves. Think value-based insurance design things, and just use those three approaches in a big, powerful way to hit this one thing. You can succeed.
You know,
Reminded that the NHLBI funded the barbershop hypertension project. Lawton Cooper was reminding me of that, and I'm glad that he's one of our audience here. Lawton, thank you. Nancy, you were going to say something.
I would love to just make a comment about the PSA. One of the things we need to really do if we get to the point where we can get a PSA out is really focus on how patients need to understand that they can control their health. And in fact, they are in charge of controlling their health. Many patients with heart failure, when they're feeling bad, they end up in the ER or call their doctor because they don't understand there are things they could do on their own at home to take care of themselves. And we like to say, especially now in the COVID era, you know, you only spend about 1% of time either in a doctor's office or in a hospital. The rest of the time you are at home with your family and living your life. And so what we need to do is help patients understand how they can control heart failure. Maybe they need to decrease the sodium in their diet if they ate pizza 2 days ago, or maybe they need to take on less fluid, or maybe they need to be better at taking their medications as ordered. But we need to help them understand that they're in charge of their health. And oftentimes when we do qualitative research studies, we learn that many patients don't feel like they have any control over the heart failure. And so they just let it get worse to the point and end up in the ER. We need to turn that around. And a PSA can not only help recognize, but it can help patients to understand that they are in control of their health.
So another question from the audience, and if it's Jim Young, I think it is Jim Young, talking about health literacy and how we don't often identify that the patients have a poor health literacy in whatever it is that we're giving them or talking to them. We're going to move on to improving treatment. And Norm, I want to come to you because let's just briefly talk about blood pressure again. We have dozens of blood pressure medications that work. And I think one of the successes of the SPRINT trial was that the docs weren't told what they needed to give. They just said, lower the blood pressure. Here's a list of drugs. This is the blood pressure we want to get to. And there's been some talk out there of the poly pill. What does Cedar think of the poly pill? And what would it take?
We've had a number of conversations with potential sponsors for poly pill. You know, a drug that a product that includes usually several antihypertensives and other generally helpful cardiovascular drugs. But nobody has seemed to be able to figure out how to make any money doing this. The barriers to approving a product of this nature aren't very high, but the return on that investment to a sponsor apparently isn't high enough to make it worth people doing. You know, I mean, if you know the country or you know some organization were to pursue something of this nature. And I think one of the managed care places has been co-packaging drugs they want people to use together. I mean, that, you know, that's possible to do. It's not that we won't approve one.
I found in our heart failure clinic in New York that blister packs were very important for adherence, because the blister pack would just say breakfast, lunch, dinner, bedtime. And it was something very simple. And we had pharmacies who were willing to do that for our patients who were specifically having the adherence problem. And you know, the hypertensives are feeling fine. And, you know, you're telling them to take a drug for something that might happen to them, but they're feeling okay, you know, until they have the stroke, and then they're not okay, or they just die. And like I said, I lost a friend this year, a very close, dear friend of mine, a young woman who kept hearing about her blood pressure, didn't do anything. We all found out by looking at her old medical records because she had never told any of us. She had a major cerebral bleed and lasted a week and was gone. And so it's really come to hit me how important it is to have, here was an intelligent woman with excellent health literacy who just wasn't doing it, unaware perhaps of how severe the consequences were. So I think if anything, you know, Lawton is reminding me that a poly pill for heart failure is of much public health and potential. And it's very hard to come up with a poly pill for heart failure because we manage each drug separately. You know, we up titrate this one and then we down titrate something else. So again, that's where the patient engagement. So anybody else want to comment on the treatment side of things before I move on?
I was going to say, I think Amy's comment earlier was really important because we have to listen to patients in terms of their side effects. That's extremely important. And I think that's one of the things that makes managing heart failure in a clinical setting very different is the heterogeneity. Some patients manifest their swelling and their edema, as Amy was saying, in their face or their knees or their fingertips. You know, other patients, every time they take their medications, they feel dizzy an hour, 30 minutes to an hour later. And so I spend a lot of time sort of educating patients about how to stagger medications in order to avoid those side effects. And that can be one of the most challenging things is the heterogeneity from patient to patient and how to sort of overcome some of those barriers to improve adherence, but to also make patients feel good. And that can be really challenging when you think about something like a poly pill and how to find that right balance.
Amy, I think that you can help us by telling us how we as providers can make the patients more comfortable with sharing with us the side effects of the medications that we're giving them. And it may be daunting to have to say to your doctor, well, this drug makes me feel terrible. I don't want to take it. And not being honest. Do you want to comment on that? I think it's a very important point.
Sure, absolutely. I think two things that I want to kind of speak about is one is kind of how I noticed everybody on the panel was speaking about blood pressure. So for me, particularly, like I was stating, my heart failure came into pass from, issues from the family side, but I also, a few years prior to that, dealt with chemo. So these were things that I didn't know. So you do have folks that heart failure comes on from other, obstacles versus just the heart failure. So I think you need something also for those individuals so that way they understand. And in regards of the whole aspect of understanding the medication, for me, I had a medication, for example, I had a medication that I was on and I had to go speak to my doctor because it was making me hallucinate. So I'm moving around trying to step away from stuff that was nowhere around in my house. And I had to let my doctor know, like, yeah, this isn't gonna work. I can't walk around like this. But like I said, I was very lucky. I had a great doctor. What I tell people is if you have a doctor that they're not listening to you, find one that will.
Well, we have some questions in the queue here. One of them I'm going to address to Nancy. What tests can primary care start to make the diagnosis of heart failure?
Certainly there's lab tests that can be done. We always want to rule out other factors. So of course, somebody should have a complete blood count. They should have a basic chemistry test. For sure, we want to get a BNP or an N-terminal pro-BNP just to see what the heart function is like. If somebody's having chest pain, they may need to get other biomarkers like a troponin. But we want to get at least those basic tests done. And then if we think that it could be heart failure, obviously an EKG just to see if we've got a wide QRS or a left ventricular bundle branch block. But then we should probably get an echocardiogram as well, a 2D echocardiogram. And that picture will give us a lot. In the lab tests, we often get thyroid function. Again, we look to see if there's other causes of fatigue and dyspnea and those common symptoms. So, we may find out it's iron deficiency anemia. We may need to get a ferritin level. But there's a standard list of tests that are commonly done and easy to get at any center. I think what will really help us overall is if maybe part of the this big roadmap includes a playbook for healthcare professionals that don't deal with heart failure day in and day out, and for whatever reason, don't pick up the guidelines and keep up with them. So maybe if there was a playbook that had these simple, a list of all the types of assessment factors are important, that would be really beneficial.
Thank you, Nancy. I hope that answered the question from the audience. So I'm going to move into the last piece. It's table 6 in the roadmap, and it has to do with improving patient monitoring and follow-up. And I think in this COVID pandemic, it's really made us realize some patients we may not need to see all the time in person. We can talk to them through something that's trustworthy, telehealth. And some we know that we can't do it by telehealth. We have to bring them in and we have to see them. So, Amy, let me ask you your follow-up that you get now. How often do you see your cardiologist who takes care of your heart failure?
I roughly see my cardiologist once, depending on if my symptoms are bad, then obviously I talk to them more. But most of the time throughout this timeline, I've seen them about every 3 to 6 months. And one of the good things about that, he checks in on me, even if it's by email, even if it's by video chat as we're doing now.
So Joe, I'm going to look to CMS for this one. Payments for frequent visits that don't often get covered. Amy says she sees hers 3 to 6 months unless she's sicker. I usually don't trust any patient beyond about a month. I have to see them more often than that. And I realize that many of those visits may not be covered. What can CMS do?
So I think what I want to do is sometimes these are intractable problems, right? Whether the questionnaire, the Kansas City, questionnaire or is paid for, whether we can have so many visits, some patients need more visits and telehealth may work for some and not for others, improve telehealth, but allow more in-person visits and pay for them and all of that. How do you deal with all of that? And I think that one thing we're going to have to do though is get out of the individual sort of fee for service. Here's a service, it's important. Let's have a code for that. Let's pay for that. Here's another service. Here's another service. Here's another item. Here's another service. What you're doing with that is inviting big government micromanagement of every detail. And so I'm not saying those things are bad. Of course they're good, right? But I'm wondering if they become intractable problems. There's a long laundry list. And the question is, yes, these are real problems, but who's the best person to solve them? And so if it's just these rifle shots on individual items and services in a fee-for-service mindset, there's no end to that. And I think we're trying to get away from that. So in the big picture, going this into a bundled payment program is a better way of doing that, right? Having bundled payments not be for heart failure, right? For all cardiac disease is a better way to do this. And what that does is it offloads the complexity from government bureaucrats who, I will just volunteer, may know less about how to treat your patients, right? Or if you're a patient, how to treat you. I'm just gonna throw that out there, not that that's the official government position.
You must be listening to us behind walls.
So when you do that, when you have bundled payments, you're offloading some of those day-to-day decisions onto the care providers, hopefully in shared decision-making with the patients, right? And so if you think this patient needs this, you can do this. The perfect example is that SPRINT trial where it said, look, here's the outcomes we want you to hit. Here's a list of FDA-approved things that have been demonstrated to work. There's clinical utility. You figure out the details. Now, bundled payments should not be, right? So what am I talking about here? What are the best vehicles to incentivize the changes we all seek, which is improved patient health outcomes, right? And I think going to these increasing levels of accountability is better. So you go to the bundled payment program. That's not an end in itself. This is not a way to say we're checking that box so we don't have to be in an APM or an ACO, advanced payment model, and we don't have to go into the thorny pathway of MIPS, the merit-based incentive payment program, which was designed to be a thorny pathway when they wrote the legislation. So we're going to stop here. No, bundled payments should be, we're going to get comfortable with greater accountability as a stepping stone to eventually becoming an accountable care organization. Higher, which means two-sided risk. We're accountable, but what are you doing? What was the original idea that I think we could all agree with? It's let's offload some of these detailed complexities away from the people in bureaucracy making this and that decision, and offloading it. So whether you get the CT, MRI, whether, you know, this is the way, these are the drugs you're using to, along with basic preventive measures, leveraging social equity, all of this, how you get to the better health outcomes. What are the surrogate measures? Blood pressure itself is in an intermediate level. It's a surrogate measure that actually is meaningful, right? How do you get that? Offload that to the providers and the patients themselves. And that is the way to, that's the direction to go to. As opposed to, how do I get paid for this? How do I, you know, an endless list of items and services where if we're paying for them and coding for them, and it's an individual thing with individual criteria that then changes every year or two and we never quite keep up, that's inviting a level of government intervention that everybody agrees is probably not appropriate.
Thank you. I think that you just laid it out beautifully. We're going to have to wrap up, so I'm going to go to each one of you. I want you to give me one short-term thing we can do with this roadmap to make it a reality, and one long-term thing. And Carolyn, I'm going to start with you because you're on the top of my screen. One short-term and one long-term.
Sure. I think we've come up with some great ideas. I think from my perspective, we touched on the importance of adherence. I think we need to also think about the access and cost barriers. So whether it's Joe brought up kind of value-based insurance design, like throwing out, payment for low value care. If we hone in on what we think are the high value care services, whether it's part of a bundled payment, that's all, access and addressing some of those barriers for patients to access those, pharmaceuticals or services or screenings is, I think, a short-term thing that is very important to address. And then, long-term, I think was, again, from our perspective, selfishly is ensuring that we're developing the right types of medicines that are going to work for patients. As you brought up, the very rare type of heart failure medication, which was just, approved. We're making advances all the time. And so I think we're really excited about the science. And so, the scientific part, I think, and really honing in on the root of these diseases will be the long-term, solution for us. But I think short-term, we definitely have an affordability and access problem. So that's a barrier.
Thank you. Alana?
I'd love to see, sort of toolkits aimed at the patient and the provider for engagement so that patients understand what medicines they're supposed to be on so that they can ask their clinician, this is what I'm supposed to be on. If I'm not on it, why not? And the same thing for the providers. This is what all patients with either HFrEF or HFpEF in an ideal world should be on. And if they're not on them, why not?
Joe, your turn.
Oh, sorry, Joe. Yes. Okay. So the short term, now remember, I'm representing my own views. These are not the views of the US government. This is just an idea we're brainstorming. I want to run this by my wingman in government who thinks a lot like I do, Steve Farmer, see what he says. So do not put this in your pocket. Short term, we write people on here, public, private, a perspective piece, or even better, something that shows up in Red Book or Vogue or The Atlantic or something like that, right? Something real people actually read. So we get two versions of it. And we talk about a national program, kind of like smoking cessation, for blood pressure, the thing that you've been paying all along. It's one simple, clear thing, right? And we have that three-legged stool. So we have the social equity stuff, which Carolyn and others so eloquently spoke to. We have the, we incentivize it, and we're part of that. Like, how do you reward patients and providers for doing X? And the whole idea of value-based insurance design originally from Mark was don't incentivize patients to go in one direction and doctors to go in a different direction, align the supply and demand of this. So that's the second leg. The third leg would be the, so we have the social equity, we have the incentives that are aligned, and then finally we have public service announcements. Someone else had said that out there. It's a public-private thing. We've got this whole COVID, Operation Warp Speed, public-private success. Let's build on that. It's led by the Surgeon General. Why? Because that person did it before for smoking. We hit blood pressure. So short term, it's out there. It's out there in a perspective piece, but then it's out there in something so much more important, like Red Book or whatever. I don't even know, but that's an example, right? Long term, we actually execute on doing this.
Thank you. Vandana.
Hi, yeah. So both short-term and long-term, I think one of the highest priority items is blood pressure control, as we've been discussing. I think about that in three parts. One is increasing patient engagement. The other is community health programs. And we know there are models that have worked, the barbershop and others, and research studies have shown that they work. So can we expand those to areas that need it? And the third is using technology to make virtual visits easier, to make sort of to facilitate both the clinician's life and the patient's life in order to improve blood pressure management. Long-term, I think this extends to the diagnosis of HFpEF, making the diagnosis better, easier to understand, but also blood pressure control is also a part of that, the subtypes that need blood pressure control to prevent the development of HFpEF.
Thank you. Norm.
So, I mean, I don't think I have much to offer that people haven't already said. I think blood pressure is probably the highest leverage thing to do. Will pay dividends for decades if you can manage it. I'm not too keen on the classic public service announcement. I don't think people so much listen to commercial radio or watch commercial TV so much these days. The place where I think you might have more impact is to, leverage some of the technology that's used in digital assistance. And once you've made contact with people, get them to subscribe to some service, where they get reminded to take their drugs on a daily basis and get probed for, adverse reactions, get at least a box, if not a person, that interacts with them and reinforces what you want them to do.
Thank you. Nance?
From a short-term perspective, I think one of the biggest things we need to really focus on, in addition to what was talked about from a prevention standpoint, is to really help our providers out there give the right drugs at the right dose at the right time. We have so many providers that are not heart failure experts. There are some cities that don't even have one heart failure expert. People would have to drive 100 miles to find somebody. So we have to help our primary care doctors, our internal medicine, our family practice doctors understand how to do this better. And as Elena and other people already said, we know heart failure is very complex. And so we need to figure out the right way to do it, whether it's case studies, whatever it is, so that people can understand that complexity and still help to give the right care at the right time. From a longer term perspective, I believe that we're going to learn a lot of lessons with COVID. And one of them is going to be that patients don't want to come and drive to a doctor's office, park their car, pay to park, sit around in a waiting room, wait to be seen, and then repeat the process to go home. And I think down the road, we're going to see more patients really wanting to be treated in their home. And we really need to figure out the telemedicine business better for our patients who need objective assessment. The subjective piece is easy. We could ask all the right questions and wait and hear the responses. But if we need to assess for volume overload and the patient's got a video camera that's attached to their computer and they can't show us their neck veins and their legs or different parts of their bodies, we need to find the right way to do it. CardioMEMS will never be the right way because it's too finite in terms of who even meets the criteria for it. Internal cardiac monitoring right now, otherwise that's attached to CRT and ICDs, don't have the right sensitivity and specificity. So if I'm hoping there are some technology innovators out there listening to this who will start coming up with the right ways for us from a long-term perspective, do a better job of being able to manage our patients where they're at in their home.
Yep. PSA piece from the audience, put it on Netflix, put it on some of the social media places that they will catch on. So Amy, I'm going to let you close us. Tell me what we can do short-term and long-term to make your life better.
As far as short-term goes, for me personally, I would like to speak on, and I apologize, I wrote this down. One of the first things that I did when I got diagnosed, I did the worst thing in the world. I went and Googled what was going on with me. After I Googled it, I was dead within 2 years. So obviously the information there is not the most recent. So the biggest issue I had was during my, when I was first diagnosed, was there was no immediate support group. I was diagnosed in October. The first heart failure support group was in June. So that wasn't the best thing. So I think that you really need to have something going on monthly so that as a heart failure patient, I know what the heck is going on, what I need to do, especially as a new one. Now, as a veteran heart patient, I have a little more knowledge. I know not to be stressing out. I know to stay off of Google. So these were certain things I had to learn. Now, as far as long-term aspects, one of the things is I think we need to arm our primary folks better. So I think as patients, we tell our doctors, hey, my mom had heart failure, my grandmother died of a heart attack, my dad died of a heart attack. So obviously, as a doctor, you guys are like, oh, wow. And that is my true family history that I'm dealing with. So to me, this is, in my 20s, especially with my doctor having that information, that's when they should have started prepping me like, hey, I know you like steak, but let's not eat 6 of those a week. Hey, I know you like this, but let's not do that. Hey, McDonald's is probably not your best choice right now. So I think if we as people that are going to be potential heart failure folks, I think if we have if our primaries are better armed to deal with us, I think that's going to be very helpful down the road.
Words to come by. Thank you, Amy. This has been wonderful. I want to thank all our panel members. I'm sure that the National Forum is going to put this in some semblance so that we can have these actionable items. And I think there are some actionable items that we've talked about that the National Forum can either do or can get everybody together to do in those partnerships that Dr. Hutter so nicely talked about. So I'm turning it back over to you, John.
Thank you so much, Dr. Pena, for moderating today's panel. This really has been a rich, robust panel. I think that term is often overused. It certainly is appropriate and applies today. So thank you to each of our panelists. We value your perspectives and especially your commitment to action. You identified some levers to improve outcomes for people with heart failure, better education of patients through different channels, making sure the educators or messengers are relatable, leverage social equity, lower barriers to patients getting blood pressure cuffs, equip more barber shops with blood pressure cuffs and more barbers with the knowledge of what blood pressure level is normal, help patients understand they can be in control of their health, knock down payment barriers to team-based care, better equip primary care providers to help patients with blood pressure control and heart failure care, the list goes on, but a lot of those things we know work and they're actionable. So this really, you've gotten the ball into the end zone. Congratulations. Amy, I want to thank you for reminding those of us in clinical care and public health of the importance of listening to the patient. As you pointed out, you know better than anybody when something doesn't feel right. Thank you to the participants who were not on screen, but who shared valuable questions and ideas and perspectives. Hattie Hanley, James Young, Lawton Cooper, and others. Your input was seen, addressed, and it's valuable. We've captured it. Thank you. And thank you certainly to the sponsors of today's event, AstraZeneca, Boehringer Ingelheim, Lilly, and Pfizer. I often say that you can't save the world if you can't pay the rent, and you can't put on a roundtable like this without some fuel in the tank. So we greatly appreciate our sponsor support, which made today's roundtable possible. Thank you as well to my friend Jean-Luc Isolet and the wonderful team at the World Heart Federation for the opportunity to collaborate with you to host today's roundtable. Thank you to the National Forum team for a terrific job in organizing this roundtable and putting it on. Now, if you registered for this roundtable, you will be notified when the recording of today's session is available online. And I encourage you and ask that you share it with colleagues who are not able to watch live, but who may be able to help us carry out some of the actionable strategies that were identified today. And now, from the National Forum for Heart Disease and Stroke Prevention, let's join forces to implement the actions identified here today that the evidence tells us will improve heart failure patient care.